Please help me welcome again Michael Harrell. Michael is a registered respiratory therapist and is currently the Director of Clinical Education for Passy, Muir, Incorporated. His past experience includes teaching, management, and clinical practice. Michael has served as president of the Florida Society for Respiratory Care and as a leader for the Rewrite Committee for the Florida Respiratory Care Act. He has been published in various clinical journals and spoken on the national and state levels. Please welcome Michael as he presents ethical issues with patients following tracheostomy. Michael's presentation is sponsored by Passy Muir Incorporated.
Well, thank you. And isn't it interesting, Colleen, that my introduction and my information hasn't changed from this morning? I appreciate being here and being able to speak to this group again. Something of a privilege being the last talk. And I think perhaps because I get to present your one required ethics hour, you have to stick with me. And I think you know who I am. You know I'm the Director of Clinical Education with Passy Muir. I would like to point out that this talk is an educational talk, and I am in this talk not providing for you legal advice. I'm attempting to present education for you regarding ethical considerations for patients with a tracheostomy. So ethics talks can at times get to be a little boring. They can also be a little bit detached from our clinical practice on a day-to-day basis. What I'm hoping to do with this talk is make it a little bit more interesting. We're going to be talking about a little brief talk about ethics and what it is exactly, but then we're going to get into identifying specific issues that relate to ethics and our patients who have a tracheostomy. We're going to talk a lot about communication because that's one of the most significant portions of the ethical considerations, and it gets into patients' rights. And also we'll be talking about how that applies for us on a day-to-day basis. So first off, what is ethics? Well, it's really easy. The basic definition for ethics is it's a field of study regarding good and bad behavior, and what behavior is good, what behavior is bad. So that's pretty simple, isn't it? Yes, that's a simple definition. That does perhaps not come out to be quite so simple when we get down to practicing it on a day-to-day basis. We've been talking about ethics for a very, very long time in our history. The first written laws that concern ethical behavior were by Hammurabi, who was the king of Babylon, and these were written back in 1754 BC. So that's a few thousand years ago. There were some references to ethical considerations in poetry and like before that, but we don't have the written codes themselves. The first codes we have that are written are from Hammurabi. After that, think about Confucianism, you've got Buddhism, you have all kinds of world religions that have ethical statements. The Bible talks about the 10 Commandments, and even in the times of Jesus, you have the Golden Rule. So we've been talking about ethics for a very, very long time. It seems maybe we haven't quite got that right yet. Or is that really the case? Perhaps it is more the case that we change as time changes. The things we do, the things we talk about, the things we have, the technology we use all changes. And we have to learn to apply ethical principles in every situation. We as respiratory therapists are required to have ethical education on an annual basis. And I think the reason why we have to have that is pretty obvious. We have patients' lives and their health in our hands. We certainly want to exhibit good behavior as opposed to bad behavior. And we have to discuss what those behaviors look like and how does that really apply on an ongoing basis. So I wonder if you look at this picture, how many of you know what that's a picture of? Well, as I said, I'll be 68 next year, so I know that that's an iron lung. Some of you who are younger may not have recognized that. The iron lung was used back in the 1950s pretty commonly as a part of as mechanical ventilators for patients during the polio epidemic. Part of my clinical experience was at National Children's Medical Center in DC, and I had the opportunity to be put in an iron lung. It was interesting to feel what it's like to all of a sudden have the air suck in, and then it kind of comes out, and it's kind of involuntary. It's an odd feeling, I'll tell you. But mechanical ventilation doesn't look like that anymore. We have mechanical ventilators that are small, portable, and they're all microprocessed. They give graphics. They have all kinds of different options. The change in technology requires a change in the supportive care given regarding those technologies. That means we have to think about what that care should look like. It necessitates an ethics discussion in order to take care of those patients in a truly good way and in an ethical way. The ethical rubber meets the road in a codes of ethics. They're an essential part, first of all, of any profession that claims to be self-regulating. Respiratory therapy is a self-regulating profession. We have licensure in individual states, and we're governing ourselves. We have a respiratory care professional association. So we are a self-regulating profession. And what has to be in real codes of ethics? You have to ensure safe and effective patient care, obviously. That's a primary responsibility. You have to establish parameters of behavior for the professionals that are within that profession. You want to promote an atmosphere of human rights and respect and values and customs, and they have to be universal. That means they have to pertain to all professionals in that profession. I want to say here that there is a difference between codes of ethics and laws, and we'll talk more about how they relate to each other, but a code of ethics is not a law. However, codes of ethics can often be used to apply laws and in legal considerations. So they are important in a legal way. They are not the laws themselves, however. They provide the standards that those professionals are judged against. So the AARC has a statement of ethics or principles. It's on the website. You can find it easily. The AAR website is quite navigable, and I can speak from experience because using my JAWS, where I get to listen to the websites, I find my way around the AARC website pretty easily, so I'm sure you can. You ought to look them up and read them. They're important. They're how your profession and your professional behavior is defined by your own profession. So It's intended to ensure the welfare of the patient and protect the integrity of our profession. Both of those aspects are really essential when it comes to looking at codes of ethics. But what I really want to focus on in this talk here today is a focus framework for the day-to-day care and conduct we provide as we take care of our patients. So they are meant to have an influence on how we take care of our patients. Again, there are 16 principles or statements within the codes of ethics from the AARC. The wording of those statements is really interesting and important to consider. It says the respiratory therapist shall. That does not say the respiratory therapist may, the respiratory therapist might, or the respiratory therapist ought. It says the respiratory therapist shall. So it is defining expected behaviors for all respiratory therapists. And that's important to remember in what we do on a day-to-day basis as respiratory therapists. And you ought to know your code of ethics. Again, go find them, read them, and be sure you know them. As we go on and do this talk, we're going to be talking about some of those individual principles and see how they apply to our tracheostomized patients. So it might be helpful just to kind of point out that when you look at the 16 principles, they're kind of divided into 5 different basic categories or ideas. Competency. How do we take care of our patients? Patients' rights, or what do the patients that we take care of expect from us as professionals? This is a two-way street, you know. Legal compliance means we have to follow the laws. Collaboration, and it defines what that team relationship looks like, which, by the way, also includes a statement which prohibits bullying. And I think that's an important aspect, that, though it doesn't relate directly to our patients with a tracheostomy. And it talks about professional behavior acting to encourage integrity and trust. So those are the 5 kind of basic categories. And I just want to give you that framework as we think about the various principles that we'll be talking about here. So let's talk about competency first. And in the AARC statements, competency is kind of looked at in 3 different basic ideas. It says that we have to act competently. So that means that's our actions. We act competently. We have to educate ourselves in order to act competently. And we need to follow evidence-based practice. So those are 3 basic ideas that are behind the AARC idea of competency. So what is competency as far as a definition is concerned? It's simple. It's just having the necessary knowledge or skill to do something successfully. It expects us to be efficient and capable. And as respiratory therapists, in each state, we all have a scope of practice. So it always means that we are practicing within our scope of practice and not exceeding it, but also not living under our scope of practice. So, what are a few areas in the care of our patients with a tracheostomy that could have ethical considerations? And I just bring this slide up because I want you to think about this. What we cover here is by no means an exhaustive thought on ethical considerations for the trach patients, but I want you to kind of think about what implications these different areas could have for a trach patients. How about the timing of the tracheostomy and tube selection? In other words, how long does the patient remain intubated in your facility before you consider placing a tracheostomy? What kind of ethical considerations as you practice could that bring into play? When do you downsize? Thinking about when will you allow the patient the ability to communicate? How are you advancing them towards decannulation? So there's a lot of issues that could have ethical implications in that area. Communication is probably one of the most difficult and ethically fraught parts of having a tracheostomy, and we'll be discussing that pretty extensively. Swallowing, the ability to eat and nutritionally support yourself and be safe. There are ethical considerations in that area. Decannulation is always the goal when you have a tracheostomy, and the steps towards decannulation, how you get there, when you get there, and what that means to that patient and their potential for discharge and their discharge planning, all of that has serious ethical implications on a day-to-day basis. So let's talk about communication. And we'll just start by asking a couple of simple questions. Can you competently care for a patient with whom you cannot communicate? And are you better able to care for a patient with whom you can communicate? So those are just a few basic questions. So let's take a look at this. So here is an example of an answer to for those questions. This kind of situation I'm going to give you is meant to kind of help us to think about why that question we just asked is important. And this really happened. This was in a hospital in Australia, but it could be in the United States just as easily. It could be in Tennessee just as easily, and it could be in Hamilton County, where I live, just as easily. So let's think about this situation. There was a patient on a ventilator who had been put in deep sedation because he was very seriously ill and needed very aggressive mechanical ventilation. He had a very serious infection going on. He was on a high-powered antibiotic. The doctor noticed a rash, and you can see a rash there. The doctor said, "Oh no. Is this patient sensitive to this antibiotic? If he is, and I have to stop this antibiotic, what are my therapy choices for him, and how is that going to impact his outcome?" Fortunately, they remembered that this gentleman had used a speaking valve on the ventilator in the past. So the doctor decided that it was worth bringing the patient up out of this sedation, waking him up, putting the valve in place to try and see if they could get information directly from the patient. So they did it, woke the patient up, respiratory therapy, put the valve in place, and the doctor asked him, "Do you know anything about this rash? We're concerned about it." The patient said, "Oh yes, I've had psoriasis for years." Well, they put the patient back down in sedation, kept running his antibiotic. The patient recovered and did perfectly fine. But that was important information that they were not going to get unless they could communicate directly with the patient. It had direct impact on the patient's care. Patients who have communication problems are at least 3 times more likely to have some kind of negative event. That's not good. Communication is essential if we're going to take good care of our patients. So if we've got a tracheostomy patient, what are the tools we have for communicating with them? First, blinking. The once for yes, twice for no. I'm sure you've all gone through that. That's one method. Lip reading is another. Sure, you've tried that one with your trach patients and your intubated patients. Notepad, handing the patient a notepad, pencil or pen, that's another method. Communication boards and computerized communication devices, that's another whole section of communication tools that you might be able to take advantage of. Or the use of a speaking valve, that's another option. And I think that as we go on and talk just a little bit more about that, you will realize that these options are presented here in something of a hierarchy of effectiveness. There is an article that was in Laryngoscope back in 2010, and Laryngoscope is a journal that is primarily read by otolaryngologists, ENTs, speech and language pathologists. And this article was specifically on communication issues for tracheostomized patients. And they pointed out that the use of a pen and paper is not dependable for a trach patient, that the inability to speak provides all kinds of anxiety for that patient. As a matter of fact, there's been several studies that have been done that have shown that 95% of patients surveyed found the lack of the ability to communicate as the most stress-producing factor in being on a ventilator. It was ranked higher than pain. So it's obviously a real stress factor for our patients. Also, the use of devices have their own built-in problems. They have a higher likelihood of error. We may misinterpret. The patient may not use the device appropriately. Devices can break, they can be expensive. So there are problems with these kinds of augmentative type communication devices. So let's start with blinking. I'm going to play a video here, and this is a gentleman who was actually in Switzerland, but again, could apply here just as well. He was in an acute care facility where he was only able to blink to communicate. He was then transferred to a rehab center where he was able to use a speaking valve and was able to talk and communicate. So I want you to hear what his thoughts were on this process.
When I was intubated, the only thing I could make was blink my eyes, once to say yes, twice to say no. And that was a bit long, and I wouldn't communicate really with people. I would answer the questions, but I wouldn't try and really communicate with people.
So listening to what he said, what he is saying is he would answer yes or no. That's all he could answer. He would make no attempt to communicate. So he was not communicating, and there is a significant chance of misunderstanding what he means. Questions can be asked in all kinds of ways that can be misunderstood by the patient, and we can misunderstand their answer. So this is a method of communication that is pretty highly prone to errors, and we don't want errors in our communication. Obviously, if this is the only method of communication, it's the only option you have at the time, it's the most effective method you have, and you have to use it. But there are other methods, and you need to always be thinking about them. How about lip reading? Now, how many of you, and I wish I could see your hands or wish I could hear your voices, how many of you have struggled with lip reading your trach patients or your intubated patients? I have. I've not always been a blind respiratory therapist, you will remember. I remember trying to lip read. That's been pretty frustrating. Well, let's see how that really works. In just a second, I am going to play a video. This video will have no sound because we've taken the sound away from it. I want you to watch this video, and you're going to have to watch real carefully because I'm going to advance. Once I advance to this video, it's going to start and you have to watch because she makes one statement and I want to see if you can figure out what it is she's saying. So here goes. So, what do you think she said? I wonder how many. I think probably most of you. That's what I thought. I'm getting a lot of messages that say, no clue, that we don't have any idea. Yep. So I'm going to play this video again now in a second here. And she's going to say this video is going to include the sound. And let's hear what she really said.
I am a diabetic.
So you heard her say, I am a diabetic, right? How important would that information be to the caregivers to know? So that's a real issue to think about. Again, if lip reading is the only thing you've got, it's better than eye blinking, but it's not as good as vocal and verbal communication. But if it's what you've got, it's what you use, and you do the best you can with it. Now I'm going to play a patient who's on a ventilator, and you'll hear them speaking.
I would say that the Passy saved my life. It helped me to communicate with the ones that I love. And I'm called Miss Gabby now because all I do is talk. But I'm very happy that the Passy was something I could use.
So in listening to Miss Gabby, it was clear you can hear what she said. It was clear, you had no guesswork. It was obviously the most effective way to communicate. So there is a hierarchy. You have to find the most effective way of communicating if you're going to ethically, responsibly take care of your trach patients. So another one of our principles from the AARC is that we have to use evidence-based practice. And whose responsibility is it to use evidence-based practice for your patients with a tracheostomy? Is it your doctor's responsibility? Do you do just what he says or she says? Is it your department manager's job? Do you just do what your manager tells you to do? So is it your department's responsibility? I think not. I think it's your responsibility. It's my responsibility. I need to know what truly evidence-based care is. How do you find that out? How do you know when you're practicing evidence-based? How do you know what evidence-based practice is for your trach patients? Well, do some research. Have you ever used Google Scholar? It's wonderful. I can still use it, by the way. It's a great way to find current articles. It's a wonderful process. There are great websites. What's that big hospital out there in Baltimore? Johns Hopkins has a great trach website. They do a lot of work with trach patients. There's all kinds of websites. Look them up, find them. And this slide is here just because I want you to know that on the Passy website, we do have a lot of resources. So here we go with a way to find out a lot of articles. There are hundreds and hundreds of articles we have in our bibliography. They do not all relate to use of the valve. They relate to tracheostomy care in a lot of different aspects. So this is a great resource for you as you go and try to find out what is evidence-based practice for your trach patients. So find out, do some research. You care for trach patients, you need to know what is the best care. It's your job. So you have to protect the legal and personal rights of your patients, encourage your right to privacy, your consent, and acceptance or refusal of therapy. Is it more effective to obtain informed consent with a patient who can speak? What is the most effective way? Let's see. Here is another, just a little case study, if you want to call it that, regarding this particular point. And that is a gentleman who was older. He was on the ventilator with a chronic condition. He was not likely to come off the ventilator. He was terminal. The patient had no advance directive, and the patient's family had no idea what the patient's thoughts were regarding end-of-life decisions. The patient was not in a condition to be able to write, and they would have a difficult time even determining if he was mentally competent to make that decision. What were they going to do? Well, they got together. Respiratory was in the room, nursing was in the room, the patient's son was in the room, and the doctor was in the room. They asked the patient, and they were depending now on lip reading. The doctor tried to explain what the situation was. They asked him a few questions to nod his head and the like, just to make sure that he had comprehension of what they were saying. And it appeared that he did. And they asked him, after explaining that if we turn the ventilator off, you will not survive, do you want us to turn off your ventilator? Unanimously, the group believed that he said yes. Now, as a respiratory therapist, how confident are you going to be based on that process for taking his ventilator away and watching him die? That's a big and significant question. So, fortunately, the nurse remembered that he had a speaking valve back in the drawer in the nurse's station. So he went and got it. The respiratory therapist put the valve in the ventilator circuit, and they asked a few other questions just to make sure that he could talk, made sure he understood what they were saying, and they repeated the question and said, do you want us to turn off your ventilator? The patient's answer was no. Regardless of how you feel about extending the life of someone who is totally technology dependent, it is our ethical responsibility, according to these principles put out by the AARC and legal considerations, by the way, to comply with the patient's wishes. Communication was an important part of complying. So that's an important illustration of how essential it is to have the most effective way of communicating with your patients when you want to know what their decisions are going to be. So, respiratory therapists have to comply, obviously, with state and federal and all local laws. That's pretty apparent. How does that relate to our patients with a tracheostomy, and how does that involve us? Well, first of all, you have a law called the Americans with Disabilities Act, which, by the way, I have a personal fondness for. for obvious reasons. Now, those of you who remember that I am a blind respiratory therapist will know that if you hand me a document, I'm really unlikely to be able to know what you're trying to tell me. Not going to do me very much good. The ADA emphasizes that people with various communication disabilities will use different kinds of disabilities need different kinds of communication. For example, I, as a blind person, need verbal or auditory communications. I need to hear it. Or you'd have to communicate with me in Braille, because I do read Braille, although not very well. But the optimum and most effective way to communicate with a blind person is by speaking to them and getting them to speak to you. On the other hand, a person who is deaf is not likely to be effectively communicated with by talking to them, expecting them to answer you. You have to use other methods of communication. So, the ADA, by the way, applies to all hospitals in every program and in every service area. It applies to wherever patients have to communicate or interact with hospital staff. That pretty much covers just about everything, doesn't it? So, effective communication, I like this, is particularly important in a hospital setting because errors in communication could result in significant harm to patients. So, is a notepad for a deaf person an ADA compliant way of communicating with that individual? Well, first of all, let me tell you a little bit about sign language, because this is something important to understand if you're going to deal with this issue. Many people who are deaf have learned sign language. Sign language that is most commonly used by most deaf people is American Sign Language, or ASL. ASL does not follow the typical English syntax or grammatical structure. It is totally different. It is nothing like what you see written down or what you speak. It is a totally different language. So, if you write a sentence down to a deaf person whose primary language is American Sign Language, they may or may not understand what you have written down. And they may write you something back which may or may not reflect what they really mean for you to understand. So you have to think about this. I'm going to give you another story that is absolutely true. There was a hospital who was trying to communicate with a deaf person in making decisions. He requested a sign language interpreter. The hospital denied that request and gave him a notepad and wrote back and forth. That gentleman sued the hospital under the rules and the laws of the ADA. What was the decision? So that Mr. Abernathy was very unlikely to be able to communicate because the method they used was fraught with potential errors. It could be interpreted as manipulation because that was not his primary language, and they could and were certainly responsible to provide a sign language interpreter for him. So communication is important. Your tracheostomy patients have the same needs. So we have to find the best and most effective way of communicating with them, even under the laws that are held in the ADA. Obamacare is what we call this thing. They've made some changes to the way your hospitals are reimbursed. One of them that pertains to what we're talking about is that your hospitals are reimbursed in part upon the results of patient satisfaction surveys. not only do they get information that helps them reimburse, but they also get understanding about your facility through these surveys. So let's take a look at the survey. If you look at the survey, there are at least 16 questions that relate to communication. Nursing, the physician, related to their medications, discharge planning, all of this relates to communication. So if you're ineffective at communicating with your trach patients, you're likely to get some pretty bad marks on that survey. And that indicates to Medicare that that's an area that you're not doing a very good job in. So communication makes a difference even in that area. JCAHO, I don't think they're called JCAHO anymore. I think they're just joint commissioners, some such thing like that. They've changed their names a few times. I'm old enough to remember them way back when they were just JCAH. Then I got used to JCAHO. Now I got to get used to something else. Oh, well. Anyway, they talk considerably about communication because they say that those who are actively involved in their patient care have much better outcomes, and their participation in their care depends heavily on communication. So though JCAHO is not a law, JCAHO is a credentialing body and affects your hospital and what you do in your practice. So that is how communication relates to the laws and how you function as respiratory therapists in your facility. Now, another aspect, another principle by the AARC is that we have to function in a respectful and functioning interdisciplinary team. What does that mean for our patients with a tracheostomy? So when we're talking about an interdisciplinary management team for our trach patients, we're talking about, first of all, a whole galaxy of caregivers: nursing, respiratory therapy, speech and language pathology, the physician, physical therapy, occupational therapy, nutritional support, case management, discharge planning. They're all parts of that team. So the team taking care of your patient needs to include all of those people. And all of those people need to be educated and know what they're doing and know what their role is and know how to take care of those tracheostomized patients. And this article by Dr. Hefner, who, by the way, is a great person. I've had a little bit of an opportunity to work with him, and I just found him to be someone who I very much respect. But he has written a lot of articles on tracheostomies, tracheostomy care, patients with tracheostomies. And in this article, he's pointing out that there are many, many articles out there that have shown over and over and over again that patients who have a tracheostomy have better outcomes and shorter times to decannulation if they are cared for by an interdisciplinary team that includes all of the caregivers. And an important aspect of this team is that it must use some type of protocol, some type of pathway that the patient's progress can be compared against. When those two aspects of the team are used, they will have fewer negative outcomes, fewer incidents. They will have better outcomes, shorter tracheostomy times towards decannulation, and will do a much, much better job. So it's important for us when we take care of our patients with a tracheostomy to develop a tracheostomy care team. So I'll just give you a little example in my own experience where I worked in the hospital there in Punta Gorda, Florida. the thing that actually got me involved with Passy Muir in the first place was that I answered the phone one day in respiratory, and the nurse tells me, your medical director, whose name I won't tell you, is up here and says, if somebody doesn't come up here and plug this patient's tracheostomy tube, he's going to use chewing gum and plug it. And I said, oh boy, I better come up and see what's up. So I went up, see, there was in the chart really very little about this man. He had a size 8 Shiley tracheostomy tube. He had no decannulation process at all in place. So I went just to did a little bit of research to find out what kind of tracheostomy tubes did the hospital use typically. Did we have fenestrated? Did we not have fenestrated? What sizes did we use? What types? Because we in respiratory didn't handle the tracheostomy tubes. We just took care of them once they were placed. I found out all kinds of awful things. No one knew what kind of tubes we had. I finally had to get them in my hand and say, okay, this is this. I know what these are. As a result, at any rate, I wrote a concern to our quality management department. And as a result, I got chosen as a person to run a focus group on artificial airway care. We ultimately developed a team. That team did a lot of research and found a lot of articles by Dr. Hefner anyway. And as a result, developed an artificial airway care pathway. We did a lot of education of the nursing, respiratory, speech, and language staff, developed all kinds of standards and the like. It was a lot of work, but it made a lot of difference for our trach patients. We were able to document a lot of difference. It was when JCAHO came for their inspection, I had to do one of those poster presentations for them, and the speech and language pathologist and I got together and wrote an article which was featured in the quality management journal for JCAHO. So that process is what we're talking about. That's the kind of process that it takes to properly manage a tracheostomy patient and avoid negative outcomes. So that's just to give you a little example. So here is a video that just shows you briefly what teamwork can look like on the ground. This is at Barlow Hospital, and the people in this video are a nurse, a respiratory therapist, and speech and language pathologist. And this is a particularly good one because I love the juicy suctioning in it.
Okay, good. Let's see, have you the patients cough it up? Anything in your mouth, Asha? No. Okay, catch your breath for a second, okay? Slow deep breath. Good, slow deep breath. You feel comfortable?
Yeah.
Okay.
You feel too much air, or is the air is okay?
No.
It's okay?
Yeah.
Okay.
Okay, take a deep breath and go ahead and say ah for me. Deep breath and then ah. Good. Try to breathe in through your nose like you're smelling something. And then ah. Much better. Good job. Okay, Asha.
I just think that shows a nice teamwork. It shows that they do have a protocol, they knew what they were doing, and they worked really well together as a team. Another important aspect is handoff communication. That's an important part of your caring for your trach patients. When your patient care is going to be handed off from you to the next shift, or you're transferring the patient to another unit or to another facility, be sure that all of the information necessary for that patient's care goes with that patient. Communication to the next caregivers is essential. This article back in 2016 in the Washington Post identified medical errors as the third largest cause of death in the United States. That's not good. They also said that one of the most significant causes of medical errors is poor patient handoff. So be aware of your ability to give good and meaningful information and complete information for your trach patients whenever you're going to hand the care off to someone else. Be complete and thorough. Continuing education is another aspect. It's another pillar. It's another principle identified by the AARC, and that's important. There is a lot of education that's available for tracheostomy care, and I just want to again point out, I can't help but point out because it's the website I'm the most familiar with. We have lots and lots of educational opportunities on the Passy Muir website. And they're not all just about the Passy Muir valve. Lots of them are, but some of them are not. Deals with trach care and the like. And we're developing a new aspect to our website that I think in the future you're going to find interesting, which will get even into far more issues about trach care. And I think you'll really appreciate that once that comes out. But it's just to provide a resource for you. That's all. Now, I know you've been listening to me. I've gotten lots of comments that I've heard as I go on with the presentation, but I can hear the wheels turning even if I can't hear them spoken. All of that sounds great, but it all takes time. I managed a respiratory care department for 25 years. I know time is a real problem. You have a lot of productivity issues to deal with. You're pressed to do more with less, to see more patients with fewer respiratory therapists. I understand that. But it doesn't change the fact that we still need to provide the most ethical and the best care for each individual patient we can. Now, another limitation or potential barrier is the lack of resources. And I know that in some smaller hospitals, you don't have as many resources for ethics considerations. There's not as much of a library for you to refer to, but you still have the internet. You can sometimes have a lack of professionals who you can discuss ethical considerations with. And a really important aspect of ethical care is the ethics committee or the group of people who you can take problems to, that if you have an issue for your trach patient, you can take it to this ethics committee who can help kind of work through that decision-making process. I know those are all considerations and that they are all real problems. But ultimately, who's responsible for determining the balance of providing ethical care for your patients? It's you and me and everyone who takes care of patients. We are ultimately responsible. We can't put the blame or put the problems on someone else. We have to make individual decisions and do what is individually right in every individual situation. And I hope that this has brought things home a little bit to some kind of practical way, and made the ethics talk a little bit more meaningful on a day-to-day basis. I am finished with the presentation. I'm ready to answer any questions that there may be, and I appreciate your attending. And now I know we're done.
Hey, thanks, Mike. Great job. Once again, you got many, many comments about what a great speaker and how they appreciated this presentation. So if everybody would hang on and not log out, I will tell you in a minute how to get your contact hours. So we had one question and one comment, Mike, I'd like to share with you. The first question is regarding the PMV and ethics. Manufacturer says valve must come off when patient's sleeping, but many patients object. Is it unethical to let the patient keep it on while sleeping? Had one patient tell me she would never take it off. It had been on for 2 years.
Oh, That is a real concern, and thank you for that question. That's a good question. And let me explain. The reason Passy Muir recommends that the valve not be worn during sleep is that we do not have an FDA-approved indication for using the valve during sleep. So we as a manufacturer cannot recommend its use during sleep. There has been, in the last few years, some recent studies that have been done on use of the valve during sleep, so that perhaps we could get that indication added to our list of indications. So you're bringing up a very good consideration. There is a way around it, however, and that is that, of course, think about this first. How often do you plug a trach for 24 hours when they are sleeping? And which is going to be more traumatic for your patients, plugging or wearing the valve? So, I mean, that it doesn't have any clinical implication. There are no clinical reasons. But if your patient, if they're under your care in a hospital, a long-term care facility, or as an outpatient and you're the respiratory therapist, you can always get an order from the physician just stating that it's okay for the patient to use it, or you could document that the patient refuses to take it off. That means it is not any longer a responsibility for you, but it's not an ethical consideration as far as the patient's care. It is not a clinical concern. It's really, from our standpoint, really just an FDA indication problem.
Thank you, Mike. That was a very thorough answer. I have no more questions, but I do have one comment I'd like to share with you. And she says, not a question, but wanted to say that Mr. Mike Harrell has always been one of my favorite speakers. And this was one amazing ethics session. Thank you. So thanks, Mike, and I'm sure we'll see you next year.